What's your plan to watch the game today? I have to watch my neighbor's NFL Sunday ticket. It's not your best plan. Do you know what it is? My plan from Verizon. Isn't this here? Get an NFL Sunday ticket from you.
Oh, what was that?
It's a website that I had opened had an ad.
Okay. I was like, oh, what was that? Okay, so I'm going to start again. Okay. Welcome to Taking Charge of My Cancer podcast, episode 29. I am Derly Munoz, your host, and I have a pleasure to have an excellent medical oncologist with me, Dr. Coy Heldermon. So Dr. Heldermon is an associate professor of medicine and breast cancer specialist in the division of Hematology Oncology here at the UF health system. In addition, he's a lysosomal storage disease specialist, and he helped establish and directs the pediatric and adult multidisciplinary lysosomal storage disease clinic here at UF. He is an oncologist and a researcher and performs xenografts of breast cancer into mice to develop better breast cancer treatment approach. He specialized in mouse models of disease and use of experimental treatments. His interest is a lot to do with breast cancer and research in both clinical and academic. As a breast oncologist, he is really aware of the shortcomings of conventional therapies for breast cancer, and in particular, inflammatory breast cancer. His laboratory is currently performing studies in patient-derived xenograft tumors in collaboration with several investigators at the University of Florida. These models were obtained from Dr. Alana Welm laboratory, as well characterized with respect to expression levels of estrogen receptor, progesterone receptor, HER2, EGFR, and HER3, and tumor histology. In addition to these models, he has his own patient-derived xenography, where he pretty much, sorry, I just kind of lost tracking here. Xenography models and generically engineered mouse models of P53 and BRCA1 deficits. So he has pretty much has a deficit. So BRCA1 deficiency to allow drugs testing is in an individualized manner to better serve our patients. In addition, he is a lysosomal storage disease specialist, like I mentioned before, and an established direct care with the pediatric and adult multidisciplinary clinic. So I can continue talking more and more about the amazing things that you've been doing, but I'm sure you're going to tell us a lot more about it. So thank you, Dr. Heldermon, for being here with me today.
My pleasure.
Okay, perfect. So you want to tell us about your mission?
Well, I mean, I treat patients and help develop and translate therapeutics. That's the very short version.
And then how do you end up becoming, like, do you ever thought about becoming a physician and a medical oncologist?
Well, so my goal since junior high has been to develop a gene therapy for inherited disease. Subsequently, I expanded that to more than just inherited diseases, but that's still a primary driver. So my whole career has been about getting to that point.
Okay, right. Were you ever thought about doing something else besides being a physician?
So prior to that, prior to junior high, my goal was to become the world's first honest politician. Somewhere in junior high is when I realized I wouldn't be the first, but and I couldn't be successful. So
that was a good change right there. All right. So I've been knowing you for many years now here, and patients absolutely love the work that you do with them. I know you more for like working a lot with breast cancer patients. So if you can give them 3 valuable tips, for their journey, like if they have to be dealing with chemotherapy either prior to surgery or after surgery, what will be those?
so it's a little different than so valuable tips that I've learned along my journey is perseverance and goal setting are key with the plan to achieve, but also to account for detours. That probably still could apply to the cancer patient journey.
Yeah.
Perseverance, trying to look at the long goals, but also relishing what is going on at the moment. I.e., the moments that you have that are good, you need to appreciate, stop and smell the roses. But keeping the long goal in mind, I think, is part of that process.
Good. That's one. Any other valuable tip for your journey or their journey?
Not really. I mean, I think those are the main things. You need to find clinicians that you trust, and then you need to trust them. And you need to bring people with you who will be your advocates. While I appreciate nice patients, don't be too nice. You need to stand up for yourself, and that part of that means speaking up for yourself and letting your carers know what's going on. Don't try to tough anything out, because we can't address side effects if we don't know about them, and we can't adjust dosages of things if we don't know that there's an issue. So I guess it's a bunch of colloquialisms almost.
Yeah, no, that's a very good tip, and that's actually something that I've been learning along with the patients treating cancer is, sometimes they just sometimes are like, okay, if you're the physician or you're the therapist or you are who you are and you're telling me this is what I need to do, I'm going to do it because you're telling me to do so. And sometimes, yes, I encourage them to just say, no, if you have any doubts and you don't like it and you're not agree, speak up, right? Get a second opinion. If, Dr. Heldermon is amazing, but if you're not really trusting that, get a second opinion, it's just, you're just going to be part of it, and you're part of the team. So you just need to be acting like a part of the team. So
yes. And there are personality things that some people's personalities just clash, right? And so finding someone you're comfortable with I think, helps to foster those relationships. So it's not something, it doesn't matter whether you offend your physician in one sense, but it's not a big deal to find another physician.
Exactly. So would you explain in general to our audience, I'm sure a lot of them know about neoadjuvant therapy versus adjuvant therapy, but if we're looking into breast cancer, would you explain to them like why choosing one versus surgery, why talking about neoadjuvant therapy, which means chemo before surgery versus surgery?
Sure. So primarily, reasons to do therapy before surgery are so you get an evaluation of how effective that therapy is against your tumor as opposed to the average tumor. B, if you can downstage the tumor and make it easier for the surgeon to cut things out without having to take quite as much tissue, that'll improve your side effects from surgery, possibly even spare you a large dissection of the lymph nodes in the armpit area. And if you can spare that, then you reduce the odds of lymphedema, which can be a debilitating side effect of surgery and radiation. So all of that alone is enough. And then after that, depending on how you respond, if you have a complete response, then I know your prognosis is exceptional, and you do as well. But if you don't, then it allows us to adapt therapy to follow that on with other things that will reduce the risk of recurrence. If we do the therapy after, we don't have that opportunity. And also, that allows us to potentially tailor the therapy to your tumor.
Mm-hmm. Perfect. That's a very well explanation. Another thing I come across a lot is this, oncotype. So you want to tell us a little bit, like patients go to surgery and they're like, well, I'm waiting on oncotype to see if I need to go chemo versus waiting for that to go into radiation. So you want to tell us a little bit more about what is that means?
Sure. So there are a number of molecular profiling services available. Oncotype is one, MammaPrint's another. There are others as well. That what they do is they take pieces of the tumor, they isolate the tumor cells, and then isolate the RNA from those tumor cells. And from the relative amounts of certain RNAs, they can tell the likelihood that tumor will respond to chemotherapy. And also give a better refinement of our risk of, or our estimate of the risk of recurrence. So if you've got a very high risk of recurrence, it's a lot more likely that chemotherapy will help reduce your risk. If you've got a low likelihood of recurrence, then chemotherapy either won't benefit you at all or might only provide minimal benefit.
Got you. And then why doing chemo before radiation? Like on those situations after surgery?
So you don't have to do chemo before radiation. There are a few situations that, or a few patients that get what's called radiation recall, which means they've had radiation in the past and then I give chemo. And for whatever reason, the regions that have been radiated react like they've been re-irradiated. And so along the entire area of the breast, you get this massive redness, like you've got another sunburn from being re-irradiated.
Yep.
Doesn't happen commonly, but it does happen. So in order to minimize that, we often try to do the chemo up front. And then theoretically, although probably not a significant effect, theoretically, you want to get rid of the cells that are circulating, and that's what the chemotherapy is doing. It's hitting systemic disease, whereas surgery and radiation is more for the visible disease that's in the breast.
Got you. Okay, that's a very good explanation on that. The other thing is, how about triple negative patients? Will you just kind of tell us a little bit more about, like, again, when we have, a hormone positive, ER positive, sometimes it's like, okay, this is kind of like the best tumor to have because we know was getting to that tumor and how we can block it. So what is, from the medical oncology standpoint, the approach for triple negative?
So triple negatives, as you said, we look for three main proteins that are often present on breast cancer cells: estrogen receptor, progesterone receptor, and HER2, which stands for human epidermal growth factor receptor type 2. But we call it HER2. In the old days, like the 70s, actually probably the 80s, when we first figured out what HER2 did, the HER2 positive group was the absolute worst. They recurred quickly, killed people quickly. In the late 80s, early 90s, Herceptin came along, which is an antibody to HER2. And that was transformative. It changed HER2 from being the worst of the worst to being better. The estrogen receptor and progesterone receptor indicate that estrogen is one of the fuels for the tumor. And so we've known for more than 100 years that modulating estrogen levels can sometimes cause responses. If we drive down estrogen levels in the body, we can dramatically increase the odds of tumor shrinking or not growing. And so those are targeted therapies, either the anti-estrogen or the anti-HER2. And then we have non-targeted therapies, which is chemotherapy, which is essentially poison. And so our job as medical oncologists is to balance the amount of poison we're giving you versus and its effects on you versus the odds of killing the cancer. And so that's why we have to know about side effects so that we can modulate that appropriately. Triple negatives, they don't express any of the targeted therapies. So we're kind of limited in large part to just the chemotherapies. Over the last couple of years, there's been an increased ability to use immunotherapies, so things that help your immune system to recognize the tumor. And for triple negatives, this is a more valuable approach because it provides us at least some targeting and increases the odds of us getting a good response.
Got you, got you. Are you guys doing immunotherapy in the neoadjuvant as well?
Yeah.
Fine. Okay, great. That's good to know. Is that something newer?
Yes, last couple of years.
Okay, great. That's great. Yeah, I keep hearing more and more like about it, like looking into some research into that. And then just go.
Technically, Herceptin is an immunotherapy too. It's just we're literally bringing an antibody to the molecule that's on the cancer cell. So it's sort of like a heat-seeking missile. It brings it there and tells the immune system, hey, this isn't supposed to be here.
Okay, got you. That's a very good explanation. And then if we just gonna move a little bit away from breast cancer, I'm like so in tune with this lysosomal storage disease. Like I have no idea you were doing that. You want to explain to us what is that?
So lysosomal storage diseases are inherited diseases predominantly. And the lysosome's kind of the intestine or the digestive tract of the cell. So in every cell of the body, you have lysosomes. And if you have a defect in any enzyme that's in there, then whatever that enzyme's in charge of degrading, you don't degrade that. And depending on what it is that you're not degrading, sometimes you need to recycle more of that or eat more of that in a given cell. And so you accumulate that. So the lysosome gets bigger and bigger. It's kind of like Thanksgiving and you can't digest turkey.
Okay.
You gradually get a bigger and bigger stomach and you become obtunded. You just can't function. And that's what happens to those cells. They get bigger and bigger, distended stomachs, and then become non-functional. And that's a problem. So for some diseases that mainly manifests in the brain, and so you get neurodegeneration, you get people losing, cognitive function, and eventually function of things like regulating breathing. In some cases, it happens in the bone marrow, and then they develop pancytopenia, where they don't make enough red cells, white cells, etc. Some it's the liver and the spleen get really big. And so you can literally have a liver and spleen that take up your entire abdominal cavity and make it hard for you to eat.
Got you.
And it can manifest in the skeleton where you just have bone malformations.
Okay, got you. Super interesting. And then what do you do to try to help with that?
So for some of the diseases, we have enzyme replacement therapies.
Okay.
So you can give intravenous infusions of the enzyme that's missing and get it to most of the cells that are deficient. And that can slow down or reverse some signs of disease, maybe not all, but some or most, depending on the disease. But for most of them, we don't actually have a therapy. And so one of the things I'm doing is developing gene therapy and stem cell therapy approaches to try and treat it. That's
awesome. Wow, that's super great. So that's what you're doing on this, working with this lab to try to develop this.
Oh.
Got you. Perfect. How about what has been your most painful lesson that you learned through your journey?
Honestly, I've lived a blessed life. So I'll say that the most painful part of everything is the regulatory burden and barriers that stifle much of the translation. It just bogs things down. it's kind of like paperwork. In clinical practice, the paperwork and the fighting with the insurance is what impedes my ability to deliver care, right, for the most part. And on the research side, it's the regulatory burden and barriers that, you know, make it so that I spend a large part of my time, you know, doing the regulatory stuff, not the actual science stuff.
Yeah, it's so sad, isn't it? We have brilliant minds that should be focusing like yours in all these research and ideas and the scientific, but so sad that we have to spend all this time in all this paperwork and regulatory to fight for somebody who doesn't even know what is the science telling them, right? So this is the sad part when you fight in insurance. Okay, that's yeah, I feel your pain.
So that's the most painful part on a day-to-day basis.
Yeah. How about is anything that you have that will be of value for our audience that I have not been asking you yet?
Mainly medical skills. That's what I've developed. Medical and research skills until the therapeutics are approved, until I get them out there. That's the best I've got.
Okay, got you. So I have a question. How often, if you want to tell the audience a little bit more about, you know, neuropathy, like, you know, how often, what is this? I get a lot of questions many times from the patients, like, is this temporal? Is this going to go away? You know, what else can we do about this? So you want to, you know, expand a little bit more on that.
So sure. So certain of our chemotherapeutics are, you know, they're poisons. And so they can cause peripheral neuropathy. Sometimes consequences of the cancer can cause neuropathy, like if they grow along a nerve root, or if they cause the spinal column to compress, and you get nerve compression, that can cause neuropathy as well. And then you combine that with all the other things that, you know, as we age, we're more likely to develop neuropathy because of repetitive use injuries, or because of, you know, we develop diabetes or other such conditions that can also affect nerves. If you put those together, the odds of developing a persistent neuropathy start to grow. So the best things for neuropathy are preventative, which is always hard, right? So once you got cancer, it's hard to do any of the things that will prevent that neuropathy, such as not getting diabetes, not getting overweight. Those are things that are helpful. The other side of that is we're working on approaches to minimize that neuropathy. So the first thing you can do during treatment for neuropathy is let your doc know that you're having neuropathy, and then we can change the dose a little bit to help reduce those odds. The second thing is we've got a clinical trial right now of a compound that in mice, when I give mice that are carrying human cancers this compound, it improves the response to chemo and it prevents the neuropathy from the chemo. So we're testing to see if that works in patients.
That's awesome.
And there's some other approaches, compression, ice, that are still in development, but are pretty inexpensive interventions that could potentially help. Maintaining mobility, you know, you have to use it or you lose it. And so exercise is going to be key for everything going forward. And I know that's a lot easier to say than to do. But
Yeah. So, and then with that alone, so rehab, you know, from the PT and physical therapy standpoint, that's something that we tend to really do as you know, as soon as we can see the patients for baseline in regarding looking at the sensation, their balance, the strength, the gait pattern, and just the habit of moving and exercising. So it's easier to get that before they even start treatment, right? Versus when they already in treatment and they feel really bad. And here we are telling them, you need to do 150 minutes of aerobic exercise a week, right? And they're like, are you kidding me? I just barely can just even get up and move for 10 minutes, right? So sometimes just being really proactive and try to start early on rehab is super important for really good outcomes.
Yeah.
And as well in regarding neuropathy, from the PTA standpoint, is nothing I can do for the nerve, but certainly improving all that musculature on the feet to improve balance, to improve proprioception, to continue encourage them for mobility strength. That really makes a big difference.
And we once it's developed, we have some interventions that reduce it somewhat, but none of them are as effective as preventing.
Yep, absolutely. How about cancer-related fatigue? Do you want to tell them a little bit about that? This is something as well that we like. This is the eternal issue with a lot of our patients, even after the treatments are done, right?
Yeah. I wish I had a magic bullet for that. It's still exercise.
Yep.
Eating, eat your vegetables and go outside and play. I think part of that also involves the support group, but some people just don't have that as an option. So if I was king benevolent dictator, then every cancer patient would have a personal trainer to help them stay on diet and stay on exercise routine, right? And that would
be ideal.
A lot of problems in the world.
Yep, that's absolutely right. Yep. But I'm so glad that, and I know you do encourage, and a lot of, our department here, or like medical oncology department, really encourage the patients a lot with exercise. So, and I think that's something that has been really help us as well here. We do an embodied body composition that is able to identify, how much muscle you have, how much fat you have, how lean you are. And I think that has been a really bringing a lot of like, what I want to say, encouragement or discouragement. So when they come in and they see, oh my God, when they see actually something on numbers that represents their body, they're like, are you kidding me? I knew I have fat, but this much fat, this is disgusting. I'm going to do something about it and motivate them, because we know that, obesity leads to more issues, including breast cancer recurrence, the development of lymphedema, and with that along, all these secondary, more fatigue, more issues with that. So
yeah,
has been a really good tool, because then it's like we do it often, right? As we do our surveillance program for breast cancer patients, and every time they come and we do it, they're either like, oh my God, I need to exercise because I need to prove to you that I'm going to improve this, right? I'm going to see how my fat goes down, how my skeletal muscles goes up. So that has been a really good tool for us to use it as okay, here, this is what you need to do, and this is the exercise program you need to do to get into that. So that has been very, very helpful. It has been helpful as well that if we see a patient and they are having a very low skeletal muscle mass, and then we start worrying about, cachexia and sarcopenia and how more toxic chemo can be. So that's a very nice way for us to kind of alert you guys, kind of send you a message like, ooh, we just got to really watch on the dose on this patient, because this can be really get them down for a bad, like a worse toxicity going through chemo. So that has been very helpful for us to be able to see that in numbers, and for the patients as well on their education, and a big motivator. So that's kind of a good tool to have. You're welcome to come down to the department and we do it on you, see how much muscle you have, right? All right.
Yes, could be my motivator.
Yeah, can be your motivator. Yeah, anytime. So I'm gonna in the description of the podcast, I'm gonna write there how can people find you, but where can they find you?
I mean, obviously email works. Referrals work. If it's for research questions, you can give me a call.
Okay, and I'll put it on the description of our UF website system, so I'll put it down there. How about any books that you can recommend to the audience, and why?
Oh man, so yeah, I'm a bibliophile. I love to read. So Guns, Germs, and Steel is a classic. enjoyable romp through the happenstance, luck, and circumstances that develop our world. I find history fascinating, and history of medicine and the interaction of all of that is very interesting. And I think most people it's applicable to most people. They can see those applications. And then Terry Pratchett's Discworld series. I'm a sci-fi fantasy guy, and he created this whole world that, sits on top of elephants that sit on top of a turtle that swims through the cosmos, kind of stuff.
Oh,
It's just creative fun, and he, uses bizarre things to really speak to and describe human nature, and they're fun and quick, easy reads.
okay.
And then I've been on a history kick of late of founding fathers. So Washington by Ron Chernow, or John Adams by David McCullough, or The Three Lives of James Madison by Noah Feldman, or not quite founding father, but Theodorus Rex. It's about Theodore Roosevelt. And what I find valuable about them is you regain perspective. We tend to idolize the founding fathers,
Yep.
and lose the perspective that they're humans, and they had very human foibles, and it gives you perspective on the combative, petty, and very human nature of our founding fathers, of leaders throughout our history, and that our current political divisiveness is not actually unique in U.S. history. It's been happening over and over and over again. And the vitriol was absolutely horrible back then, and it's been through many periods of history.
Okay, that's very good. That's very good advice right there. How about podcast?
I don't watch any podcasts.
Let's not listening to this podcast.
Yeah, I'm not a regular subscriber to podcasts. I pretty much, I prefer the book. The only podcasts that I see are clips of podcasts that are like in my Facebook or, some feed of some sort. But
yeah, I have this really good one. It's called Taking Charge of My Cancer podcast. You can listen to it. It has a couple of really good speakers in there, or guests, or interviewers. Okay, how about movies?
I'm a big fan of classic cinema, but Once Upon a Time in the West. It's an epic, huge screen, great music, background music. Bronson and Henry Fonda, and it's just epic stuff. Same, couple of decades later, Dances with Wolves. Similar concept, but also romantic and beautiful and sad, and but also has action. And then cleaving to my sci-fi, The Fifth Element.
Yes,
it's got a bit of everything: romantic comedy, sci-fi western, political commentary, some spiritual aspects, all while being completely wacky. And so yes.
Great. Okay, so to wrap up, is any other question that that you feel that you would like me to ask and you'll have answered it?
No idea.
One more question. I do have one more question. So for your hormone endocrine therapy, right? So your hormone blockers. Is anything, so I come across a lot of patients who, again, because the secondary effects, right? So I feel terrible, my joints hurt all over, fog brain, hot flashes, etc. So what will be your best advice to them, like to help them to make a decision to just really take them or not?
So my first advice is to try it. Mm-hmm. And the reason for that is that the effects of hormone deprivation are not on off, but they are coming on and then coming off. So none of it's long term. Some of my patients have no side effects at all. And you don't know who's going to have side effects and who's not going to have side effects. Some side effects are very manageable. Some are very not manageable. And if they're not manageable and the benefits are not worth your side effects, then that's a reasonable medical decision to make. But you won't know if you don't try.
Okay.
And so it's better to try, and if it's just not worth it based on your side effects to the drug, and it's not something that we can modulate with anything else, then it's, it's like taking anything else. If your side effects are not enough benefit to make it worth it,
Got you. Okay.
then that's a reasonable decision to make.
Okay.
We do have some things, for aches, there's a proportion of the population that has inherently low vitamin D levels. And for those people, restoring their vitamin D does wonders.
Okay.
For people who have normal vitamin D, it's not going to do much good.
Okay.
But for the people who are low, it does.
Okay. So it's better to have like an actually blood work or somehow knowing exactly where their vitamin D is before they start taking vitamin D supplements.
So before you take vitamin D supplements, it's probably a reasonable plan.
Okay.
And so, yeah, I mean, we have multiple guidelines suggesting calcium and vitamin D, but the data is only showing benefit in select subgroups, not for general populations.
Okay. Good to know.
So, I mean, I'm not opposed to vitamin D and calcium. It's not unlikely to hurt you significantly, but it's unlikely to help you unless you're in the groups that we've shown that it helps.
Okay, that's good to know. Perfect. And the other question I have is, so sometimes women who are postmenopausal and they don't really have a good reaction at all with those, AIs type of drugs. And sometimes just you guys have to go back down to tamoxifen. So how good is that in a postmenopausal woman versus, premenopausal?
Well, tamoxifen is, I mean, it was it's our longest standing anti-estrogen therapy, right? Outside of cutting out ovaries. It's been around since 1970. So okay. We've got a lot of experience. So we know the risks and we know the side effects. Increased clot risk, increased cataract risk, increased uterine cancer and uterine bleeding risk. So if you don't have a uterus, uterine bleeding is not a big deal, and you're not going to get uterine cancer. If you're very active, then the clotting risk goes down, and you don't smoke, and that sort of thing. If you've already had cataract surgery, you're not going to develop cataracts. Head-to-head, tamoxifen is about 80% as effective as letrozole, anastrozole, exemestane. So it's still quite effective.
Okay.
And tamoxifen the dose for tamoxifen was determined back in the 60s and 70s when everything in cancer was give as much as we can until the patient can't stand anymore, right? Well, that's where tamoxifen got dosed.
Okay.
So if you're a petite person, then we might be able to go down on the dose of tamoxifen.
Okay.
And still be every bit as effective because we may just be oversaturating you.
Okay.
So that's yet more incentive to exercise and lose weight and that sort of thing.
That's great to know. That's very good to know. That can be another great piece of information for the patients who are like doubting. Sometimes they're coming like, I don't know what to do. And what will you do? You'll be on my shoes, this kind of situation, right? So I always tell them, you have great physicians and they're really great with research. They're going to give you the facts, if it's worth it or not. and if it is worth the side effects otherwise, versus the recurrence. So
the other thing that I relay to patients is, I think some of the musculoskeletal manifestations of the aromatase inhibitors, some of that's the anti-estrogen, but some of it's the stuff that's in the pill that's not the drug.
Okay.
And when you make a pill, you have your drug, your active drug, but you also have things like polysorbitol and PEG and dye and all this other stuff that goes into making it look the same for every pill, and that keeps the drug together, because a lot of drugs, they won't compress into things that maintain a form.
Okay.
And I've had patients who were on an aromatase inhibitor, and then the pharmacy changed them from one brand of that to another brand of that.
It's better.
And that's when they got the side effects. And when we switched them back, the side effects went away.
Oh, that's very interesting. That's very good to know.
And so I don't know that that's a large proportion of those patients, but for some patients it is. And a third to half the time when I switch from one aromatase inhibitor to another aromatase inhibitor, so drug still doing the same thing, but different compounding, those side effects improve.
Okay.
So we play around with switching drugs, making sure vitamin D's up, and potentially ultimately switching to tamoxifen, and if they're of normal weight or petite, going down on the dose.
Okay.
And occasionally I've even done less frequent dosings of the aromatase inhibitor. That's a little easier with the exemestane. There's some data now showing that exemestane, it has a longer half-life in its active part, so it binds irreversibly, and so it'll hit in that pocket, and so you might not need quite as much.
Okay.
When you dose it less frequently, it's less effective, but like dosing it daily versus every other day, you go from 99 to 95% effective, if that makes sense.
Yeah, got you. Okay.
But if you try to go to once a week, then it's only about half as effective.
Okay, got you.
So we can sometimes play with that. I don't like to play with that as much because that varies and is going to be dependent a bit on, again, volume of distribution. If you're a larger person, that's going to be less likely to work.
Got you. Okay, perfect. And the last question, I promise, because I can keep you here on and on with all this amount of questions, is what are your thoughts about fasting prior to actually infusions for chemo?
So theoretically, a fasting or intermittent fasting or low calorie diet constant might be beneficial for cancer. We don't know. It's hard to do those studies. We've done lots of dietary studies in breast cancer, the vast majority of which didn't show any positive results, but the vast majority of the time, patients don't comply with that diet, right? It's hard to change your diet. That's why only 5% of people can maintain weight loss for long term. The interventions that have shown benefit on a randomized basis have been like doing a Mediterranean diet, but in order to maintain a Mediterranean diet, they had people with daily reminders, weekly visits with a nutritionist for, on the order of months to years. And we just don't have the resources for that. I wish we did. It would do more than many of the things that we do that are medical. Fasting around the time of chemo, there's some phase 1, phase 2 kind of data showing improvement in side effects, possibly improvement in the effectiveness of the chemo. That's a little harder to tease out. In mice, when we give them either low calorie or fasting, it slows down growth of cancer. right? So, and can make chemo more responsive. It can also seemingly reduce side effects. Whether that's, we don't have well done large randomized studies of doing that, because it's hard to do well done randomized studies, and there's not a drug company who's going to sell fasting. Right? That's just not going to happen. Though that does bring up the possibility with the new weight loss drugs. They inhibit appetite, right? So they block, basically people don't have a desire to eat. So it'll be interesting to see how that affects things. Now, teasing apart, is that because you're losing weight?
And that's why right. I see where you're coming. Yeah.
We do know that people who are obese and have gastric bypass surgeries or weight loss surgeries, they have lower cancer recurrence rate or cancer occurrence rates. So it seems like a no-brainer that a drug that diminishes appetite and causes weight loss would potentially reduce your odds of occurrence or recurrence. And if there's truth to the effects on side effects, now granted they have their own side effects in terms of nausea and etc., but yeah, hopefully we can get a trial for that soon.
Yes, and with those lines as well goes exercise, right?
Yes,
was a really good research done in mice. We did that like right before COVID. I did that when he presented over the Cancer Institute here about like getting this mice is running on treadmills prior to chemo and radiation, and it has been always kind of like, since then I actually try to get patients in here right before the infusions, and we work them out, and then we send them up there for infusions. And again, no way to prove if the effectiveness of chemo is better or not, because we don't have a way to prove that. But side effects, definitely, I would say 90% of them so much better respond with side effects, for sure. So that has been super great.
I tell my patients, there was a large study of the UK. They followed 27,000 patients, and they just prospectively tracked their activity. And there was a linear decline in risk of heart attack, stroke, cancer of the colon, cancer of the breast, and risk of death with every step you take per day up to 10,000 steps. So 5's better than 4, 9's better than 5, 10's better than 9. The great thing about that is 10 is the inflection point. So 20,000 steps didn't reduce your risk of death or cancer or stroke. It did reduce your risk of MI, but any more than 10,000. So 10,000 steps a day is my goal for my patients.
Okay.
And, you don't have to do that all at once. But, you walk a couple of miles and that's 5,000 steps. And they also track the most active 30 minutes a day. And is roughly a 3 to 3.5 minute mile. So steady walking pace, not speed. That was the sweet spot in terms of reduction of those risks. That's not maximum cardiac capacity or any of that, but it's reduction in your long-term risk. So if they did that, that would do more to make sure they were alive in 10 years than almost anything I'm giving them.
Okay, right. That's very good. That's a very good study right there. Awesome. Well, like I said before, we can keep chatting here all afternoon, but I know it's time to let you go. That was super helpful. Thank you so much for being here with me today and bringing all this valuable information to the audience.
Thank you. We appreciate your partnering with us to care for these patients.
Thank you. I'll appreciate it. You have a great evening.
You too. Bye.